Spring break for everybody. Okay, my clinical group. At the end of your lunchtime, I think isn't your lunch till 12 o'clock? So about 11:45, if you can meet me in my office, I'll take you one at a time. I've already did your midterm conference with me, so you didn't need to sign your, I don't know if the blue thing or whatever, for our progression of the program. At that time, I will hand you back your IPRs. Yeah. I'll hand those back. And what is your salary introduction?
It's due next week, right?
No.
Nice try, Kim. Thank you.
Okay? All right. Good to have you back, Ray. You sleeping?
I'm on her schedule,
All right. We left off last week. Is there any questions, any inquiries, any statements before we start?
Do we know Alzheimer's? I don't remember. Did we go over that? Yeah. Obviously, I was late. You know, definitely.
Ask her where she was last night.
Obviously.
Ask her why she was late and where she was last night.
Okay.
I followed.
Okay, fine.
Did you?
Yes.
She was walking around.
Ask her where she was. She was late today.
She was late.
Mhm.
She asked a question, there's a case study on diabetes.
I'll ask her.
Okay, just do things as they fall. You know, the case study, get it done. Okay. All right, except for we're a week behind, but we'll get caught up. Okay, we left. Oh, there's something else I got to say. Did Professor Bethune have a study session with yesterday? Yeah. She did? For those who came?
Yes.
Okay. I have to work with block 1 tomorrow. Is there anyone available Thursday that wants to? Yes. Okay, so let's do Thursday at 10 instead of Wednesday. I'm trying to vacillate between two areas. Okay, trigeminal neuralgia. Before we even start there, do you guys remember your cranial nerves? Fairly.
Negative.
Okay. There's 12 of them. There's 12 of them. And there's little rhymes how to remember them. The only ones you need to associate with for this test is trigeminal nerve number 5, which is it's a trigeminal nerve. The condition is trigeminal neuralgia. So cranial nerve number 5. The other nerve that you will be associating with on this exam is cranial nerve number 7. Facial nerve. Facial nerve. Facial. The other one that we talk about eye and ear, so you need to know the acoustic. You probably know it by something else, but it's acoustic. I'll talk to that when we get there. Okay, so trigeminal nerve. In your books, some books will call it Del-Root. Just remember trigeminal nerve. Cranial nerve number 5. What happens with the individual is there's severe reoccurrence, so there's a relapsing and remitting that can occur. They can get it again. It's a severe recurrent sharp facial pain along the trigeminal nerve. It's usually unilateral, one side. What you'll see with the patient at the time upon assessment, they may express pain along the lips, gums, nose, or across the cheeks. So, a pertinent question you would ask the patient if they came in and you're trying to decipher with the physician whether or not it's involvement of the trigeminal nerve, has there been any pain along the lips that was not perpetrated from any type of injury. It just started on its own. Pain along the lips, gums, nose, or across the cheeks. Also, a patient may say to you, I'm having more difficulty now chewing. So pain along the lips, it starts, they may have trouble chewing, and they may start having pain that is isolated to itself, nothing else perpetrated. Situations that stimulate symptoms is extreme cold. So this happens to people when the weather changes from like fall to winter. When these people have this condition, they even have difficulty if someone just kind of touches their face, like you're trying to just touch the face, have that intimate type of sensation, it hurts then. Washing the face, chewing, and foods that have extreme temperatures, be it hot or cold. So, with this person, what type of foods would you be getting? Definitely soft. It's not the time to give them some hot soup. It's not the time to tell them, oh, let's just go have a cold brew. So basically, you want to give them soft foods at the time of the incident. Soft foods, non-spicy foods, and foods that have a moderate temperature. So if you had a question that stated, what would aggravate or exacerbate these symptoms? All of these things. Extreme temperatures. Any tactile stimulation to the face. This happens to show the trigeminal nerve, where it starts, right near the ear, the jaw coming on down, and all the nerve roots of that nerve. Thus, you have a problem with chewing.
Is that the nerve that's affected if you get a dry socket from like a wisdom tooth?
Yes, it goes
Oh
along that
my
nerve.
gosh, that is the worst thing ever.
Oh. And here's another grouping of it, laterally, how it goes into pain that's referred.
Thank you.
It may start initially from the trigeminal nerve and it radiates out. It's referred and radiating pain. Here's another a way where you know where the person has all the sensations on the face, front of the face. What do you want to do? Avoid hot and cold foods. Extremes. Provide small feedings of liquid and soft foods. It generally happens unilateral, so you want that person to chew on the unaffected side if there's something they have to chew. This is a joke I'm going to say. But some people in my clinical group would have a problem if they had trigeminal neuralgia because they like to chew gum. Okay? And you want to administer medications, mild analgesics, non-narcotic, to ease their pain. Here are some other medications that would be given to them because of the neuralgia. They could have medication Tegretol. Where have we heard that before? With seizures, but in this case, it's given so it soothes actually it decreases the sensations that nerve is innervating to the face. Dilatation, anticonvulsant, but it's also used for neuralgia. Leorasil, which is a muscle relaxant. You want to relax that face. Elavil, some people associate it with it as only for antidepressant, but no, it helps decrease that person's sensation. And good old Valium is given. Not only for anxiety, but to decrease the sensations that the person is having.
If they have pain in the mouth, you know, if it was mainly the mouth, would they give them like a lidocaine type rinse?
It,
like my patient was on?
Lidocaine may
The
be
one that they
given
do that rinse.
just to the mouth, but remember it's usually unilateral, so you're gonna numb the other side too. But it's possible,
Would it hit the nerve?
but that's not
though?
one of the main ones. Again, if they were given Tegretol or Dilantin, what do we remember about Dilantin? What's the side effect of Dilantin? The gums.
Drowsy? Oh, the bleeding.
They can have the hyperplasia of the gums. What else do we know about Dilantin and Tegretol? Therapeutic levels, especially with seizures. But in this case, we're giving it to decrease the onset of the or the exacerbation of the neuralgia. Okay, these before I go to the next slide, these people are a safety risk because you're giving a medication that alters their sensations, and at times it can alter their mentation. So therefore, once you give them, you need to be monitoring for alertness, orientation, and making sure that you delegate that maybe to your nurse practitioner on this person readily. What can be given to this person? Not so much used as the first one. An alcohol injection along the infected portion. Not so much used. Rhizotomy or total severance of the nerve. All it's saying is that nerve root of the trigeminal nerve is severed. The others are things that can be done where it relocates the artery and compresses the trigeminal nerve. The one thing you want to decrease the activation of that nerve to different areas. But the thing you need to, with a rhizotomy, if it's total severance, say I had it manifested on the right side. Say I have the surgery today. If you come into my room tomorrow, it is normal to see paralysis on this side. It is normal because they severed that nerve. Thus, that potentiated and caused the paralysis. This person has the paralysis because they're not happy. You want that nerve root severed so they don't have the pain. That is a last resort if they're not responding to medication management. Once it's severed, it's not the time to tell your patient that it can be reversed. This is permanent. It is expected. So if you had a question that you're assessing your patient after a rhizotomy, a total rhizotomy, we'll put that, I'll say the nerve is severed, and you come in and you see asymmetry of the face. The affected side that you knew occurred before, was going on before surgery, is now paralyzed. Is this normal? Yes. It is not a trick question.
And it's permanent, you said?
Yeah, just like, it's gonna look similar to Bell's palsy.
That's like pretty severe.
That we're gonna talk about. But that's severe. They try to catch them with the Tegretol or Dilantin and Valium. Okay. Bell's palsy, cranial nerve number 7, facial nerve. It can occur because of trauma, hemorrhage, a sequela or a disorder that occurs after meningitis, or it can be a tumor along that cranial nerve 7. It is unilateral, predominantly. Recovery occurs in a few weeks without residual effects. So, you'll hear the word self-limiting. Is Bell's palsy self-limiting? Yes. Is it reversible? Yes. Because after the person, the recovery phase is occurred for a couple of weeks, this person does not have residual. Can they go into it again? Yes. And this is just showing where the facial nerve, remember we have the trigeminal nerve up here, and the facial nerve begins down here. And it's nerve roots. Flaccidity of facial muscles. So, if someone's flaccid on one side, what problems do you think they may have? Drooling. What else?
Your eye.
Their
Swallowing.
eye will probably just be relaxed, almost like a ptosis may occur. So what do you need to do if the eye is affected and here it is, the person doesn't have control of any tearing, they don't have control of any drooling, what do you need to be doing with the eye? Lubricate with some saline. If there's infected process, there may be antimicrobial drop, but generally it's saline. Lubricate the eye. Wash the eye, aerate the whole face but the eye. What about oral care? You need to do that frequently. They can't control their secretions on that side. What about eating? What would you have them do?
Chew on the other side.
Chew. You want to give them soft food, but you want them to try to chew on the unaffected side. With these people, when they're trying to close their eye, it's the opposite effect. They're trying to close their eye and it just kind of curls on itself. And you know how the kids back in the day used to try to freak everybody out and have your eyes flip up.
Oh gosh.
Sometimes that occurs. Or they may just have a ptosis, which is straight down. Either way, you need to provide eye care.
Would an eye patch?
Patch might work at times temporarily. Loss of taste on the affected side. So would you expect this person to be eating much or wanting to? If they've lost that taste, they are not wanting to take in foods that normally they would take in. This is a picture of it. Of course, this is the unaffected.
That's the effect.
No. He looks weird either way you look. But anyway, eyeballs rolled up, eyelid does not close. You're giving the saline drops. Forehead not wrinkled, it's relaxed. Flat nasal, nose, and the lips, folds. You don't see the folds because everything is relaxed on that side.
So do they sleep with one eye open?
Doesn't close all the way.
Even though some people sleep with one eye open and they're normal, these people sleep with one eye open, and Shirley said a patch would work. Definitely. What psychosocial issue would this person have during the time? Well, it may be depressing, but what would come first? Body image disturbance?
Mhm.
Can you imagine a 25-year-old female who's like to trot and having no falling? Okay? Okay. Encourage active facial exercise to prevent the loss of muscle tone. So what could you have them do? Try to smile, frown, okay, grit your teeth. You want those muscles not to atrophy. So what exercises are you doing? Isometric to the face. Isometric exercises to the face. Now, there are facial slings that are provided, however, that's another body image thing. A lot of people may use it during times they're at home, but out in public, they may choose not to use the facial sling. And the sling is for those weak muscles and just kind of pulls it up. And as we stated, protect the eyes from dryness and to prevent injury. So you're going to use those saline drops, you're going to use the eye patch. especially at night.
What's a facial flame?
What are we supposed to do?
Okay, you see these people who are vain and want their face to be up there? Okay, it kind of goes like this. So you have the unaffected and the affected side, which is really slim.
Like a fabric.
It just holds it up. That's why people don't want to wear it. It looks like you got injury somewhere and you have to hold everything up. But it's there. It's possible to use that. You want to provide oral care. They don't have control of their secretions. What are they high risk for then if they can't control their secretions? Aspiration. Skin breakdown. Okay. Huh?
Skin breakdown, like.
There might be skin breakdown from the constant moisture in that area. Here again, instruct the client to chew on the unaffected side. You heard the same thing with trigeminal neuralgia. Administer analgesics and corticosteroids. You're given the corticosteroids for the inflammatory response. You're given the corticosteroids for the inflammatory response that's going on. Is this self-limiting? Yes. Can it reoccur? Yes. Okay. So, cranial nerve number 5, cranial nerve number 7. Okay, Guillain-Barré syndrome. I'm not French or whatever, but it's called Guillain-Barré syndrome. This is a condition that is self-limiting. It can occur, but it goes away after it runs its course. It's an acute infectious neuronitis, in other words, an irritation to the nerve of the cranial and peripheral nerves. It's autoimmune disorder. What happens, this person may have had some type of infective process occurring 2 weeks prior. So a pertinent question you would ask this person if you and the medical team suspects this person has Guillain-Barré, you need to ask them, have you had an infective process in the prior 2 weeks? Yes.
Is this sometimes an allergic reaction to, I had somebody, a patient one time in Coco said they had Guillain-Barré as a reaction to a flu shot.
Yes.
That's not a myth?
Okay, it's not an infective. In that case with the flu, they reacted to the flu and then it perpetrated this condition to occur.
So they probably would have gotten that if they had gotten flu as well.
Right.
Well,
Go ahead.
because when I give a flu shot, it's actually on the directions that you should always ask if they're allergic to egg whites or eggs
That's
and
different.
Guillain-Barré syndrome.
So again, as
Is it
issue, the person is going to say to you, I've had some type of infection in the prior 2 weeks. Okay. What happens, the infective process destroys the myelin sheath of the nerve, the covering of the nerve. It's usually an upper respiratory infection. Flu is a respiratory infective process. It can also be as a result of a GI type of infective process, like gastroenteritis. Now, depending on the person's immune system before they ever acquired this disorder, which is autoimmune, there are some people who can go a year with this disorder, but it's self-limiting. Self-limiting means that if it's a year that it takes for them to recover, after that year they recover. But if they have another infective process, they can get the disorder again. I'll say that again. Guillain-Barré, even though it's occurring in the person, it's a slow process. Even though they're getting better, you need to say to the person, your recovery will take a while. It's not the time for you to think that you can go full swing back to work. You can go back to work, but you need to alert your employer that you're still in the recovery phase. It is self-limiting, but the person can get a flare-up again when they have another infective process. The thing you need to remember is usually it can be a respiratory problem that perpetrated this disorder, but what you need to watch for with this person if they have any difficulty breathing. ABC. A major concern is if they have difficulty breathing. Other things you should ask that person, do they have any paresthesia? Arms, legs. Usually the manifestation is weakness of the lower extremities. They start having some weakness. So you have the infective process, then a couple of weeks later they notice they have some weakness of the lower extremities. The weakness can move up to the upper extremities and the facial muscles. If the weakness moves up, what activates and is a problem with respiratory is it diminishes the intercostal muscles to contract and relax. The reason why it's respiratory that you need to watch for is the intercostal muscles become too relaxed and they don't have the effort to breathe in, breathe out. It can result in respiratory failure. They can have cardiac arrhythmias because it affects musculature also. Okay, and diagnostically, what we can do with these people is do cerebral spinal fluid, which you do a spinal tap on these people, and you can do EEG because that goes with nerves. You want to treat symptoms. You want to monitor the respiratory status. You give respiratory support. If they need O2, you give them O2. If they're really debilitated, you might have to have more concentration of O2, not just nasal cannula. Give family support as to referrals to maybe support groups out there if there are there, and also assist them in knowing how to help this person with their degree of immobility. So these individuals might need to have a mechanical assist, like maybe a cane or a walker for a short period.
What's the usual recovery time? If it's still processed or what?
Okay, remember I said it depends on the immune system of the person. For test purposes, you need to know that you need to tell the person that you'll have progressive increase in your activity. It's going to take you some time. It may be up to a year, but each person is different. Test purposes, you should say that it will take a length of time. It's not the time to go full force at work or any activity. There's another PowerPoint it talks about back pain. I've done just actually a few questions in class, not on the test, about back injury pain. We're going to talk about multiple sclerosis and Lou Gehrig's disease.
Those are on the test.
The ones that are on the test are multiple sclerosis and Lou Gehrig's. Okay.
Is that multiple sclerosis PowerPoint? Is that the one?
Yeah. Okay, tell me quickly, what are some important things that you need to teach the general public as well as the patient about preventing back injury? Other than MBAs or bungee jumping and all that.
If it's close to your body.
Huh? You said it, Sid.
Lift with your leg, not with your back.
Lift with your legs, not with your back. What did you say?
Bend your knees.
Bend your knees. What else? Somebody come over here.
Wow.
Go ahead, Karen.
I don't know. That's pretty much covers it.
Huh? Have a partner if you need to pick up anything. Body mechanics, sit upright. Some of us are like this, and some people are just too relaxed, you know? So, body mechanics when you're sitting, back up straight. What types of jobs or activities would predispose a person that we do every day? Let's talk about occupation.
DNA.
CNA is poor thing. Okay. Huh? PT. Physical therapy. But what do you need to wear when you're helping any patient? Gait belts, okay.
Those don't exist.
Gait belts? Yes, they do. You just don't have one.
They're so hard to find.
Yeah.
PT always wears them.
They're in our soil utility room.
Okay, so what you said, you want to lift with your legs, keep things close to you. If you feel that you can't lift something, or you sense it, you get another person to help. If it is a patient, why do we put those draw sheets in there? So that it helps us to lift that person. Get another person to help you lift that person. It's not and plus you're going to cause injury to the patient if you go under the axilla trying to pull them up. And once you try to pull them up, you've pulled your back, you've pulled all of your stomach muscles, and plus any gynecological issues you have. If you don't have them, you're going to have it eventually because of your activating muscles that normally you're not going to be using. Okay. At that time. Okay. So that's all I'm saying. Okay. What medications would we use non-narcotic? Who? Non-steroidal, like your Motrin. Okay. Tylenol if you need to. And you guys know the side effects of Motrin and too much Tylenol. Okay? All right. There are sometimes that people need surgery, but we're not going there now. There are some different surgeries that are used to assist the person. We're going to read up on that. What would cause cervical neck issues? What type of occupation? What type of activity? Huh?
Bungee jumping.
Oh yeah, it would definitely help. You have some big problems with bungee jumping. But cervical neck, think of some jobs.
Dental hygienist.
Anybody who has to be like this. Secretaries, surgeons who have to look, and do. Any of those things that causes cervical strain, which could be the neck pain that they have. Any of you have ever had cervical pain in the neck? Not that you're saying the person's a pain in the neck, but you literally have pain in the neck. It just seems like it just shoots down the whole body. Okay, yes.
My ear is supposed to be curved up there.
Yours is straight.
I don't know, I have to lay on one of those little round pillows a lot, try to put the natural curve back into it. So it swells up all the time and it curves.
But you work and it doesn't hurt you as much.
I've become adapted to it, so my pain threshold level in that area is a little higher. My mom and my brother are like that too.
Okay, multiple sclerosis. Anybody have family members or dealt with someone who has multiple sclerosis?
You just met a couple of us.
All right. First of all, this is the covering of the nerve, demyelinating disease. It is also autoimmune. Okay, resulting in destruction of the CNS, myelin, and disruption in the transmission of nerve impulses. So these individuals, because they don't have the covering, and then scar tissue may set in, sclerosis, and then they don't get that innervation to certain body parts. The limbs for walking. The bowel and bladder again. There are some people with neurogenic bladder who have one in clinical just yesterday who have to have intermittent fat. Major types. Relapsing and remitting is the one that occurs more frequently. Relapsing and remitting. The person with the medication management, which we'll talk about in a few minutes, what they do is, for a while, they think, oh, I'm doing good. Some people will even say, oh, I'm healed, you know, they're into that way of thinking. Relapsing and remitting. Remember it. It is the one where that is the symptoms become more frequent and the person kind of dissipates and not having the symptoms, the remitting stage, that means the disorder is getting worse. Relapsing and remitting, when the person has this occurring more readily, the disorder is progressing more readily. So, if you see relapsing and remitting, you need to remember that.
So what is it, just the disorder is progressing?
It's progressing more readily. The person is having more scar tissue occurring, yes.
Are these like stages? Like
No, these are just different types of multiple sclerosis. The one you need to remember more readily is relapsing, remitting. Some people say waxing and waning, meaning you're getting okay, relapsing. They're relapsing back into the disorder, and they're going through a remitting phase or remission phase with medication management. There's
Basically, it seems like they're getting, their symptoms get better, but they're actually getting worse.
yes, because it's happening more often. It's kind of like I'm getting okay, but then something triggers me to get back into it again. The scar tissue builds up, and they just become more frequent.
So the cycles of relapsing and remitting happen more
Yeah,
frequently.
correct. There's progressive relapsing. There's primary progression, secondary. The one you need to remember more so is relapsing remitting because it has such a psychological effect on the patient to where they feel good some days, and then some days they're just pumped. And they just feel, for those who are looking up words that they don't understand, I say, punk is they just feel terrible. Okay? I want to make a segue and say, I know y'all look up words that you don't think that I don't, you don't understand that I say. So, keep it up, but if you want to really know what I'm saying, ask me, okay? So this person is feeling bad. This person is feeling, they're feeling really bad, and they're feeling like, oh, okay. People think they're faking sometimes. But really, it's just the scar tissue is building up, and the symptoms of this phase of relapse and remitting, the same as with, anyway, third row person, middle Lyle said, welcome. Okay. Muscle weakness and spasticity. These people actually, when they're trying to get their leg out of bed, it's kind of like it will shake till they get to the surface. Like if I was trying to get my arm down, I'd shake until I got it down. Okay. Spasticity. They're high risk for injury because in the event of them trying to do that, they're standing on one limb trying to stabilize the other limb, if it's the legs. They're fatigued. Think about it. They're trying to get from one place to another. This spasticity is going on along with the muscle weakness. Intention tremors. Who does it remind you of? Remember that day I was walking with Parkinson's? They have an intention tremor, just tremors as they're trying to get somewhere. So spasticity and tremors. I'm telling you the ones you'll see more often, even though there's no. Ataxia, difficult walking pattern. Slurred speech that occurs more readily in the remitting phase. Remitting it, no, excuse me. If someone relapses, they're back into the disorder. I catch myself. So they're going to show that slurred speech more readily. They relapse back into the disorder if they're in the relapsing phase. Slurred speech. So what are you going to do if the slurred speech occurs? What do we do when people are trying to get their thoughts out to us? Allow them time to enunciate. allow them time to enunciate, allow time to listen to the person. Don't rush them because the slurred speech will get worse. Yeah, okay. They have difficulty swallowing, so what is the texture of their food?
Soft.
Isn't it a pattern we're seeing with all these neural people? You want to give them thicket with some of their liquids. Any foods, it needs to be soft. They have visual changes. Remember when we were talking about myasthenia gravis? They have the nystagmus. What's nystagmus?
Twitching.
What'd you say?
So twitching your
The
eye.
twitching of the eye. And they also have the diplopia. So, myasthenia gravis and MS, they have the eye problems that take place. Okay. And remember when we talked about myasthenia gravis, we said some of those are the early signs you will see.
It's called nystagmus.
They may have hearing difficulties. So what would you do if someone has hearing difficulties? Come to them. You want to face them, and you don't want to yell, but you want to face them so they can look at your lips and hear what you say. Bowel and bladder dysfunction. Remember when we were talking about spinal cord injury? What might you need to assist with? Intermittent calf. Who's ever put in a calf?
Oh, April did one too.
April. Okay, April with you, your lady, she had a cold.
That was Karen. I had a guy.
Okay, yeah, he wouldn't have had a uterus.
No.
Okay, okay, what did you have to do, Karen? Share it with you.
She had a prolapsed uterus, and it looked really weird. I was cleaning, and she goes, "You're cleaning in the wrong spot." What I thought was the urethra was actually the clitoris area, and what I thought was the vaginal area was the urethra. It was all weird. So
Oh my goodness.
Did
And
she
there's
get
just-
it? Yes, she did. She was able to catheterize this person.
so
Just think this person is going
it was
home.
weird.
Did you guys teach yourself that?
She said that she was not self-cathing at home, and they think it was related to her issues that brought her into the hospital anyway.
So, if a care provider, Karen, can't visualize where it is, can you imagine a female who has a prolapsed uterus trying to visualize the urethra? So, when she went home, did she go home with an indwelling catheter? But she didn't go home.
Mm-mm.
But this might be a person that for a while may need an indwelling catheter, even though she is prescribed in the hospital to have intermittent catheter. Okay, bowel. What might you need to do with the bowel? What are the things you're going to help with bowel elimination? You guys know this. Okay, that's the last resort. Okay. You want it dietary wise? What are you going to do? Fiber. You want to increase fluids. You want to increase mobility. You don't want them to be stationary. And if this person does not have the nerve innervation to push out any bowel content, you might have to do what?
No.
You might have to assist them. There may be some rectal massage that we talked about. That time, you're helping that person. You may be grossed out, but it is helping your patient. All right. There may be some alterations in sexual function. That can be the gambit of everything. Men can have multiple sclerosis also. So just think of your thing, think in your thing. Think in your brain that there can be multiple sexual dysfunction. Okay, and there can be some cognitive changes in the late stages. Diagnosis, whatever's presenting the symptoms. Remember, with MG and MS, it's the visual changes that occur. With MS, it's the nystagmus, but they might also have some diplopia. A CT scan will show white matter density. Any CT scans. MRIs will show plaques on surfaces. Okay, you already know what you would do prior to an MRI. How would you prepare that person?
See if they have any metal in their
And you have basic things that you're bringing up for block one. You want to see if they, determine if they've had any surgeries where metal was inserted. You want to see if they have any metal on them. And you would remove it. CT scan, if they use any contrast, what would you expect?
Allergies,
Check for allergies and post to get rid of that dye.
renal function.
You want to check renal function, and you would hydrate the person. History, it is familial. So, for test purposes, if some person says, my mom and my sister had MS, I'm afraid I'm going to get it. What would be a therapeutic way of educating the patient? You're going to tell the truth, right?
Yeah.
You're going to say there is a tendency for this disorder to be genetically acquired. However, you need to seek out medical attention, medical support and diagnostics to determine if you actually have it. So tell the truth, it is hereditary acquired, and that they need to seek medical attention for a true diagnosis. You're involving the family in regards to someone being diagnosed because they may be the one who will be providing the care, and all of that gamut of stuff. Monetary issues relative to meds will be the issue sometimes, especially if they don't have adequate insurance. Another thing is you need special food. Someone has to prepare the foods for this individual, soft foods. Another thing is there are safety risks. Someone needs to be available in the home to assist them with mobility. When they get to the stage where there's irritability and confusion, someone needs to be there at all times. The family can be taught the intermittent catheterizations. The family can be taught rectal massage. The family can be taught as to knowing when the person is going into a relapsing phase. Those symptoms are going to come back, especially since we know that remitting and relapsing is the most common type of MS. Okay, we already said visual or swallowing difficulties, gait disturbances. He's going to be there, impaired vowel, bladder, speech disturbances. And with the eyes also, they can have white patches in their field. So they can have nystagmus, they can have diplopia, and they can have white spots in the visual field. We know the diagnosis, fatigue, activity intolerance, disturbed sensory perception, and that means any sensory perception from head on down. Impaired physical mobility. And it goes on. Okay. Since these people can become irritated, fighting, before they get into the confusion phase, allow patients time to keep their own routine. If they are used to getting up at 6 o'clock in the morning, guess who's getting up at 6 o'clock in the morning? You too, if they're at home. Allow patients to keep their own routine. It throws them off, and what happens is they get really agitated, and it kind of like perpetrates all their symptoms or exacerbates their symptoms. Orient the person if they're in a confused phase. You want to encourage self-care. You want to promote their autonomy. They need rest periods. They need, in conjunction with rest periods, they need times of exercise also. Okay, and place on fall precautions. that voiding schedule has to be with if the person has the ability to have some sensation, because the scar tissue is not built up, and they know when they need to void. So bladder training. Females may do self-cap. Men can use a condom cap, which is not invasive, correct? So a condom cap, but they don't stay on for various reasons. Encourage adequate fluids, high fiber diet. You want to validate the person with their feelings, and if there's a support group available, you're going to promote that. Certain medications are used. You don't have to remember these, but these are biological response modifiers. They modify. This is an autoimmune disorder, so you want to use biological response modifiers. Other things, immunosuppressive therapy. It's an autoimmune disorder, so you want to suppress that immune status. So if this person's not having the manifestations of the disorder. Steroid use from the inflammation that may occur along with the sclerosis that's occurring. What is this person high risk for if they're on steroids? Infection, because it's depressing the immune system. You want to give them antispasmodic therapy because they're spastic. Okay, let's break. About 10 minutes and we'll come back and we'll finish with Lou Gehrig's disease and then I'll do concept living.